Hi folks, in this video, we're going to use this easy mnemonic as a guide or tips for hitting diabetes management goals. So not wasting much time, let's get started. Albumin creatinine ratio. In the management of diabetes mellitus, it is crucial that you monitor to detect the number of proteins in this urine. All right. The urinary protein creatinine ratio may also be used, but regarding this particular discussion, I would like to stick with the urinary albumin creatinine ratio, which is preferred for early detection of renal disease. Now, the question arises, why not a dipstick? So if you consider this urine as dilute, all right, then what can happen is that, so we assume this is a dilute urine. This urine here can underestimate the number of proteins in the urine. So concentrations can give some changes in the relative quantity of proteins in the urine. Now, because of this, you wouldn't like to use a dipstick, but use the albumin creatinine ratio, which would correct the variations in urinary concentrations. So the specific gravity will give you a clue to that. Normally, the number of proteins in the urine should be less than 150 milligrams per day. All right. Now, out of this 150 milligrams per day, 20 of it, that is 20 milligrams, is made up of albumins. So it's very important that you use the albumin creatinine ratio to monitor so that you can detect proteinuria in the patient with diabetes mellitus. So when assessing for albumin creatinine ratio, the spot sample used may be untimed. However, morning samples are usually preferred. Normal urinary albumin creatinine ratio is less than 30 milligrams per gram. Microalbuminuria ranges from 30 to 300 milligrams per gram. It has been shown that there is a correlation between microalbuminuria and the risk for cardiovascular events. Overproteinuria is greater than 300 milligrams per gram. Aspirin reduces the risk of cardiovascular events. The American Diabetes Association guidelines also recommends aspirin for patients with a 10-year cardiovascular disease risk of greater than 10%. When the risk is between 5 and 10%, aspirin may also be prescribed based on clinical decision. So it is necessary to encourage the diabetic patient to abstain from alcohol as it makes it difficult to achieve a better glycemic control. Now, in the fasting state, alcohol may deplete glycogen storage as well as inhibit gluconeogenesis, and this may lead to hypoglycemia. Alcohol can also blunt the warning signs of hypoglycemia, such as tremor, tachycardia, sweating, blurry visions, and this may lead to hypoglycemia unawareness. Alcohol may elevate the triglycerides and derange lipoproteins. It may also elevate the blood pressure, damage the nerves, and there is also a risk of ketoacidosis. Blood pressure. An aggressive goal of less than 130 for systolic and 80 for diastolic millimeter mercury is recommended by most guidelines. However, a systolic blood pressure between 130 and 135 is acceptable. This particularly reduces the risk for stroke. Body mass index. A 5 to 10% weight loss may help achieve an adequate glucose control, improve both systolic and diastolic blood pressure, increase the HDL cholesterol, reduce the risk of cardiovascular events, as well as achieving diabetes remission. Advise and encourage the diabetic to kick smoking to the curb, as tobacco smoking impairs adequate control of blood glucose. Nicotine itself reduces insulin receptor sensitivity, and smoking may worsen the chronic complications of diabetes such as retinopathy, nephropathy, or neuropathy. Diabetes and smoking increases the risk of cardiovascular events. Diet plan. So preferably you want to involve a dietitian or a diet nurse to allow individualization of the meal plan. Refined sugars must be avoided. Artificial sweetness, if necessary, may be allowed. Include fiber and carbohydrates from fruits and vegetables. Reduce total calorie content. Low fat and non fat milk are preferred. Exercise. A simple regular exercise such as walking at least 3 days a week if possible must be encouraged. It is important to consider age and other concomitant disorders when educating patients on exercises. Fundoscopy. Patients with diabetes mellitus must be screened yearly for early detection of retinopathy, which is a major cause of blindness. Create the awareness of foot complications. Patients may wash and dry but avoid moisturizing in between toes. Trim toenails carefully and file sharp edges. Examine foot for corns, calluses, sores, cuts, and signs of inflammation and report to primary care physician. Wear socks that absorbs moisture. They should avoid traumatic activity such as walking barefoot or rubbing the foot. Shoes must also be comfortable. Glucose and glycated hemoglobin. Glycated hemoglobin should be less than 7%. Fasting blood glucose should be maintained around 6 to 8 millimole per liter. Postprandial glucose 8 to 10 millimole per liter. However, you must check with your local protocol. Diabetic patients with cardiovascular diseases must be assessed and initiated on statins irrespective of lipid levels. Immunization. Counsel patients with diabetes and make sure their immunization status is up to date. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.